My name is Maureen Baker. I'm the chair of the Professional Record Standards Body, and in this presentation I want to tell you about our work in PRSB and what that means hopefully for yourselves and for patient care. So just to say that the PRSB is a UK-wide body, although probably we do most of our development work in England, but we do in fact cover all the nations of the United Kingdom. Next slide, please. So, what do we do? So we do develop information record standards so that the right information is shared wherever and whenever it's needed. So we're sharing digitally between different systems within the NHS, because clearly patients move about from one setting to another, have different procedures, there's all sorts of different systems, and we want the right information to be there for the patient at the point of care. And I'm going to talk about our unique network. So if we can go on to the next slide, please. The PRSB has member organisations, so we're not a collection of individuals, we're a collection of organisations. Currently 61 organisations spanning health and care sectors across the UK. And here's a snapshot, as it were, of some of our members. So we have medical royal colleges, we have charities, we have professional organisations. Have a look, you may see your own organisation flagged up there, but even if it's not on that slide, it's highly likely that your organisation, your professional organisation, is a member of the PRSB. And we think we're quite unique in having both organisations representing health and care. We also have considerable input from charities, third sector, organisations representing patients and carers. We have some international connections, and increasingly we engage with the vendors of systems with respect to moving our standards forward. So we do think that we're the only organisation in the system that brings this wide range of organisations, patients, regulators, system suppliers, etc., all together for the purposes of standards for electronic records. So if we can move on to the next slide, please. Yeah, I should probably say as well that although we are a small organisation, but when you look at all the member bodies collectively represent up to 2.5 million people. So there's a lot of engagement with PRSB work. We are independent, we're not part of the NHS, and that was a strategic decision back when the PRSB was founded, to be independent of the NHS. So we're set up as a community interest company, a social enterprise. It's a not-for-profit organisation. As I've said, we are UK, and probably the majority of our member bodies are UK. They themselves are UK organisations. So it's an important point to make that we do represent all of the UK, and of course we do have links to other bodies internationally. And just to say that we believe that standards identify the critical information that's needed for safe care and safe practice. I think many people are familiar with technical standards like FHIR, fast healthcare interoperability resources. But and these are clearly essential as a vehicle to get information from one place to the next. But what is that information? You know, what do we mean when we say we use a particular term? How do we gather the information and group it and present it? So all these factors are really important in making sure that the information can flow reliably across the system and mean the same thing in each sector where it's addressed. Next slide, please. So we already have a considerable number of standards that are up and running. Do have a look at our website and you will see that all the information about our standards is there, and we've also got lots of useful blogs, news, short videos that explain more about the standard, as in what it really means to people, whether it's the professional or whether it's patient groups, whether it's carers. And looking at these videos, I think, looking at these brings it to life. It starts to spell out much more what this means, what difference these make. So, you know, these are some examples: pharmacy information, social care, transfer of care, and we've got our child health and maternity standards, outpatient letter standards. And another point I want to make is that by having these standards, we are supporting patient safety. If you look in particular the transfer of care standards, we're well aware that problems and errors and things go wrong when people move from one part of the NHS to another. So from general practice into hospital, from ambulance back into the home, from, you know, any interface where information has to be transmitted. If that goes wrong, then there are implications for patients and potential harm. And by having these standards and implementing them and adhering to them, we can make this process much safer for patients. Next slide, please. So I want to say a little bit more and talk particularly about some standards that we've recently developed. And it's important to say that again, drawing on our extensive network, our consultation processes involving the professionals, involving patients, involving carers, citizens, you know, we really put a lot of effort into doing this work really well. And frankly, our member organisations wouldn't be happy if we didn't do this work, you know, with the rigour that's needed to produce a really good product. And really, you know, the traditional process of consultation, I suppose, is, you know, you put together a letter, you send the letter out, and people respond back to the letter. And fair enough, you know, that is an element of consultation. But we like to think we've gone further in our consultation process. So people can certainly give us responses and evidence in written format, but we also run workshops. We conduct one-to-one interviews with patients, with professionals, with carers. And we do work together with NHS and social care organisations. We need these standards to work in practice. If people look at a standard and think, that doesn't apply to me, this is complete ivory tower, it doesn't relate to the real world, and the standard doesn't get used, then, you know, that work is in vain. So it's really important to us that the standards do work. They work for the professionals that use them, the patients and service users who are, you know, recipients of care. And it's important to us that we do take a personalised, holistic view, where we're really looking at the person, you know, as an individual with all their needs. I'm going to say a little bit about the About Me standard, which is one that I do recommend you have a look at on the website, because the About Me standard is a standard for the patient, for the service user, where they can put the information that's really important to them that people know. So they might want to, they might want to put how they like to be addressed. So my name is Maureen. People might call me Mo. I would hate that. I've always hated that. So, if my About Me standard would say, please call me Maureen and please don't call me Mo, for instance. But, more seriously, people might, they might want to note that they have a dog. If their dog, if the person is admitted to hospital suddenly as an emergency, there might be information about who can be contacted to look after the dog, for instance. That, there's infinite possibilities that people want to put into the About Me section, but this is the material and information that individuals think is really important to them. And by having this standard, it lets that information be disseminated to any professional who's going to deal with that person. And certainly the feedback we have from patients and carers is that this is really essential. And I say again, if you look at some of the short video clips, no more than 2 minutes, and have a look at the difference that a standard like this really makes for patients and their families, or service users and their carers, it's it's really eye-opening, and I do recommend you have a look at those. Okay, so next slide, please. Thank you. So one of our standards that we recently put together is social care pathways, and this, we're talking here about sharing information between care homes and hospitals where a patient might get emergency care. And some of you might be familiar with the red bag as a concept, as a physical thing that ambulance crews might look for and take with a patient when they're admitted to hospital. And so what we've tried to do is develop the concept of the electronic red bag. So it's the electronic version of the paper documents that previously, were physical things. And indeed, our e-red bag does incorporate the About Me information that I've stressed is really important to include. We have been able to use 2 key methods to transfer the information, focusing on particular areas. So with South West London local shared care record, and also the national record locator. We have also put together how-to guides, and an example is being able to contact the software supplier organisations who are able to implement these standards. And, we are seeing, and staff are seeing, benefits from this work. So I mentioned the South West London pilot, and 6 care homes are now live with the e-red bag, covering almost 500 beds. The original target was going to be much higher, but was reduced understandably due to COVID. Hopefully we will continue to implement and see benefits across the board. But as an example of some of the benefits, in this pilot, they've seen an 11% reduction in emergency department attendances. On average, 1.5 days reduction in length of stay, 7% reduction in readmissions, a 12% reduction in ambulance conveyances, and then also savings in both hospital staff time and care staff time. So these are not negligible. Okay, thank you. Move on to the next slide. And this is a quote from a care home manager, again to illustrate the benefit. And this person is talking about wanting to avoid extra work, and because the e-bag system, e-red bag system is available, they just need to collect a few specific bits of information to add, and then electronically that information goes to the hospital. It's much better for hospital staff, it's much better for care home staff, and fundamentally it's going to be much better for patients. Next slide, please. So there's some other examples as well, but I think that's all I want to say about the red bag. Another example we're going to give is the where clinicians, instead of writing a clinician to clinician, they're seeing great benefits from writing directly to patients using the PRSB outpatient letter standard. So these examples are from the Freeman Hospital in Newcastle, and the information that we're getting back is that patients are much happier because their views have been taken into consideration in the development of this standard. The letters are written in ways that they can understand. It's not just jargon that's meaningless to lay individuals. This information is about them, and it's written in ways that make sense to them and that they can understand. We have here a nice picture of Dr. Ian Logan, who's a consultant nephrologist, and he's been helping us work with this standard, and working with clinicians so that they have a good understanding of how to think about the information from a patient perspective. And this all just makes a big difference in the way in which patients experience care and the benefits they get from that. Next slide, please. So another standard I particularly wanted to flag up are the pharmacy information flows. So I'm sure you'll all be aware that in the last few years, pharmacies have been able to administer flu vaccinations. And that's certainly been a service that many patients and citizens find really useful. Working population, for instance, who a person doesn't need to take time off work. They can go to a local pharmacy near their place of work, get the flu vaccination there. And certainly many people take up the option of having their flu vaccination delivered at a pharmacy. However, originally when this was done, the information about that vaccination stayed with the pharmacy, didn't get to the GPs. The GPs wouldn't necessarily know which of their patients had had the flu vaccination, which didn't. That made difficulties in recall systems, people being contacted twice, wanted to know why that was, maybe even turning up for a flu vaccination when actually they'd already had one. So clearly that wasn't a desirable situation. And so the pharmacy information flow standard was a way to get information, starting with flu vaccinations, from pharmacies into GP systems. And so we started this work in 2019, been rolled out much more widely in 2020. And it has done as was intended, got the information so that the GPs and the practice teams did get that understanding of who had had their vaccination. And previously, if pharmacies had sent the information in paper format, it just took time to take that information from a document, input it into systems, check it. And one of the great benefits from this standard has been the time savings that general practice report. And as it happens, because this standard was in place, it meant that this standard was able to be used for information about COVID vaccinations. So when someone has their vaccination, COVID, that information can go from a pharmacy system where the information is entered automatically through to the GP system, and that's of great benefit. If we do move to having vaccination passport certificates for travel, that will have been a way to make sure that the information did get to the place where it needs to be in order to have this facility. And I'm really pleased that this piece of work was already in place. It didn't need to be invented to be able to deal with COVID. And as time moves on, we'll be looking to extend the areas that the pharmacy information flows will cover. Other services that pharmacies can provide, maybe weight loss services, quit smoking, things that can be used in that setting and then transferred to GPs. And there's clearly opportunities for other sectors, high street opticians, for instance, being able to use a standard such as this to get information directly into GP systems, and being able to do that. Fundamentally, it saves professional time, it's more convenient for professionals, but it's much better and safer for patients and service users. Next slide, please. And I want to finish by talking about our work with system vendors. Because frankly, the best way for a standard to be implemented with minimum amount of work involved for the professionals is for the standard to be embedded in the system that the professionals use and that patients encounter when they have care. And so, we've increasingly seen the importance of working with the vendors, the system suppliers, to be able to have these standards available, widely for use by professionals. So we're starting, and we've done a reasonable amount of work now on developing a standard partnership scheme to support the vendors who implement the standards. And it's all designed to support integrated care, to support information flow, interoperability. But by working with partners, we can get by our partners in the industry, we can allow them to demonstrate to providers that they meet PRSB standards or the relevant PRSB standards for the service that their system supports. So this is something that's sort of hot off the press. We have very considerable interest and take-up from the system suppliers, and we're hoping that the majority of them will become partners so that they are aware of PRSB work and they receive newsletters and bulletins, come to meetings, workshops, get involved indeed in the development of standards work that I've already mentioned. And there will also be, that's the sort of basic partner level. There will also be a level above that, which we're calling quality partner option. And this moves to be more of an accreditation, a sort of kite mark, where the particular system can demonstrate compliance with PRSB standards. So we're piloting that with a few organisations to start off with. We're getting very positive results, and this is something that we do see moving quite quickly now over the next year or two. And I think as professionals, it's really useful for you to know whether your systems are compliant with PRSB standards. So do have a look at our website, and indeed if you want more information, please contact us at partners@theprsb.org. Okay, and next slide. So that's us finished. Thank you very much for your attention. I can be contacted, maureen.baker@nhs.net. You can also contact us at the PRSB for any further information, and we'll always be very happy to continue discussions. Thank you very much.
Okay, great. Good morning, everyone. My name's George Harston. I'm a stroke physician in Oxford. I also work in industry, delivering AI solutions in the real world, and my background's in, and I still keep some activity in academia. Today I'm going to talk about the real world delivery of AI, and I'm going to use stroke and a stroke project as an example, but really try and pull out some of the bigger themes about the real world delivery of AI and how it contrasts perhaps to some of what we see. So can I have my slides up? I apologise. I can't see my slides. I can't see it on the main stage, but I'm assured they're up there. Okay, fine. So my disclosures, if you just click through those, unfortunately, just for those of you watching, I'm afraid I can't see the slides on the main stage I'm being presented on. So yeah. Yeah. Preview. Beg your pardon. Excellent. Thank you very much. Sorry about that. So yeah, so next slide, please. Great. These are my disclosures. And next slide, please. Great. So I think one of the key things about delivering AI or any innovation in a system is to understand the problem and to base the solution around the problem. There's a lot of examples, particularly in AI, which is a very sort of sexy field and very exciting, of solutions for the sake of a solution. And that will never solve a problem. It will never add value. And if it doesn't add value, it's not going to be sustainable. But it's quite a commonly overlooked step. And a lot of people develop an algorithm or an AI solution and then try and shoehorn it into a problem. But that really is the wrong way around to do it. It's really important to understand what the pathway or process is that you're trying to improve or change, and what that unmet need is. What's the opportunity for the solution needs to address. And key to that is who's the beneficiary of an innovation. What difference are you going to try and make, and are they really the user? So it's very easy to conflate two, that the user is typically different from the person or body or organization who benefits from an innovation. And that beneficiary might be a healthcare system, it might be a more efficient system, it might be a healthcare provider, but ultimately it always comes back to patients in healthcare, because patients pay for healthcare systems, whether it's a state-funded healthcare system like the NHS or an insurance-funded healthcare system. The patients as a whole tend to be the payers. Next slide, please. So what's the problem we're trying to solve in the context of stroke? Well, for those of you not familiar with the condition, stroke is a devastating illness which affects around 100,000 people a year in the UK, and the majority of strokes are caused by a blockage of a blood vessel that supplies the brain. That blockage causes a reduction in blood flow downstream of that blood vessel, and that part of the brain stops working, and there's an immediate effect, and you lose the function that part of the brain was helping support. And that might be a weakness down one side of the body, or a speech disturbance or visual disturbance. And these are called ischemic strokes. And the clock starts to block that blood vessel, a bit of brain liable to die, and it dies within minutes to hours after that blockage. And the mainstay of acute treatment is to open up that blood vessel and restore blood to the brain. But of course, that's a time critical thing, because after a few hours, there's very little left to save. But the good news is we have got treatments that can address this problem and can remove that clot, either using drugs or using mechanical procedures. Next slide, please. And the challenge that we have and the problem that we have that we need to solve, and AI can help contribute to, is that we miss an opportunity to treat a whole load of patients. These are evidence-based treatments which have quite a large effect, and a demonstrably good value. But even for something that's been around for many years, such as the drug called IV thrombolysis, it was first proven to be a benefit in 1995. Even then, we still in the UK probably treat about 12% of stroke patients with this treatment, whereas up to 20% or probably north of that would be eligible. And it's even worse for something called mechanical thrombectomy. And that's a procedure where you you go in under X-ray guidance, up through the groin into the or the wrist, into the brain, and pull out the clot mechanically under X-ray guidance. It's a specialist procedure, and we think that somewhere between 10 to 15% of patients would benefit from this procedure. They have the biggest types of stroke, they're the most disabling strokes, and the vast majority end up with a lifelong disability, loss of independence, or death. But we still only treat a handful of patients who have the opportunity to benefit from this procedure, but we could treat many more, up to sort of 10 to 15%. Next slide, please. So that's the unmet need. That's the problem that we might want to try and solve. So what's the patient journey? What's the sort of the problem we need to integrate with? Well, patients who have a stroke hopefully attend their hospital, their local hospital very quickly. And this will be typically a general hospital. Around about 80% of patients will go to a non-specialist centre, and they'll be treated by the people who work at the front door, who are very good in the NHS, emergency department doctors, and acute medical doctors, and hopefully they'll have pre-alerted a stroke team who will have an interest in stroke at least, and understand the stroke pathway. They'll get an urgent assessment and a scan, and that scan will be a fairly simple bit of imaging. Typically in most general hospitals, it'll be a non-contrast CT scan, very easy to get the pictures, but very difficult to interpret, as you'll see. And then increasingly something called a CT angiogram, which is another brain scan where you inject dye into the blood vessels to look at look for any blockages directly. And there you get a decision about thrombolysis, that clot-busting drug. And you may, hopefully, increasingly be identified as benefiting from a thrombectomy and require transfer to a specialist centre, a hub, as we call them, which will then decide about your eligibility for mechanical thrombectomy. So it's a fairly complex journey. And next slide, please. And imaging is key to that, and identifying patients who are going to benefit from treatment. So just to summarise that problem, you've got a time-critical issue. You've got to generate a diagnosis. You've got to come up with a management plan, and you've got to affect that management plan. And the quicker you do that, the better. Every minute that goes by, you lose 2 million neurons. Over 3 weeks of independent living. So it's really important to get this right and to make your system as efficient as possible. And at the moment, in all healthcare systems around the world, we're under-delivering, and some are worse than others. Next slide, please. So what does our problem look like? Well, this is the project just to frame where I work in Oxford at the John Radcliffe, and you can see that in green on this map. And we receive referrals routinely from these 5 typically called primary stroke centres or spoke hospitals around Oxford. And the vast majority of the patients who we should be treating in Oxford with this specialist treatment, mechanical thrombectomy, should be coming from these other sites. But how you connect these centres, identify patients for transfer in a timely manner, is what we're trying to solve. Next slide, please. And I think when you're approaching the problem, you need to frame the solution around the problem. It needs to solve the problem and not necessarily be the flashiest of the solutions available. If you want to get 5 children to school on a wet Wednesday morning, then a people carrier is the right tool for the job. It works on real roads, it's dry, it's got enough seats, and it's in your budget. it's not necessarily the fastest car available. It's not the most expensive. It's not got the best performance. It's not the one that your petrol head, your specialist wants, but it doesn't really do the job either. And this is exactly the same with artificial intelligence or any sort of innovation algorithm. So, for example, you get a lot of AI, self-proclaimed often AI experts, who will fuss about, diagnostic sensitivity, area under the curve, receiver operating characteristics, all these measures of performance equivalent to your sort of horsepower, if you like, of your engine. But actually, that's not what's important about delivering value in your healthcare system and thinking about your beneficiaries. Because although for example, your specialist radiologist might be impressed by a marginal gain, actually it's the clinical rather than the statistical significance which is all important when you're thinking about AI in healthcare. So bigger margins are to be gained by integrating well into your system, by handling all data regardless of where it's come from, and by flagging errors in real time. Next slide, please. So this slide just summarizes the sort of process of deploying AI into a real-world healthcare system. And as you'll see, the algorithm itself is actually only a small part of the chain. You do need a good performing algorithm. You've got to have good quality data. It's got to be data that's representative of that which you're going to encounter in the real world, free of biases. And that's really important. And that's why you have regulatory clearance and you have standards you have to meet for your algorithm. But the next bit you have to do, which is all important for driving adoption, both by clinicians and payers who ultimately make decisions or need to make decisions about these things, is clinical evidence. You need to show, can you benefit patients? Can you improve patient outcomes? And also, can you be adopted into clinical practice? And that's not just about clinicians. There's a whole load of other stakeholders. There's IT professionals, information governance teams, PACS providers, radiographers, radiology service providers. If they've all got to be able to work with your system, and it's got to be usable in the real world. It's got to work in real time wherever you are. Next slide, please. So the solution's got to address the problem. So what you can see on here is the solution that we're currently using in our stroke network called eStroke. And the image on the left of the screen is a non-contrast CT scan. The image next to it, the sort of black image with the white lines on it, is a CT angiogram scan. And this is the workhorse of acute stroke imaging available in all stroke centres. So this is the imaging you've got to be able to process. Advanced imaging using advanced imaging hardware is not available in most hospitals, even in the UK, which is relatively developed. The important thing is to work with the problem that you're faced. So you've got to address this simple imaging. And what the simple imaging analysis does here is it's identifying how much brain is already injured. Does this patient still have something to save? Is it appropriate to transfer them to a specialist centre? And then the image on the right is flagging to you, is there a problem that can be solved by going to a specialist centre? In this case, a blocked blood vessel, you can see highlighted with a red circle, and some downstream lack of blood flow highlighted in orange. And so it's really important that you use these, that you use the data and the information that's available to work in the real world. And so it has to sit also in the hospital system. It has to be a seamless flow of data from the scanner to the AI solution to wherever the clinicians want to use it. And it's really important it's embedded in the workflow so that it gets used and doesn't just sit there as a nice algorithm. The best algorithm in the world has no value if people don't use it or can't use it. Next slide, please. And so you have to work in not only within a hospital as well, but within a network of hospitals. And here you can see the need to speak to every hospital in a network. You've got to be able to provide the solution that supports better patient care in a spoke hospital, your general hospital, your local hospital, as much as your specialist centre, and you've got to be able to connect them as well. So we have cloud solutions which connect our local hospitals and our specialist centre so the images can be seen in real time by the specialists, and therefore minimize patient delays to get the treatment that they need as quickly as possible. Next slide, please. So And this is just to show that even when you've connected it, you need to put the results in front of the clinicians. And I hope you can see the the image on the left just shows a PACS. Obviously, the images don't really jump out of the screen, but you've got to go to where clinicians look at images. But increasingly, we've got the opportunity to go to people's mobile phones, their wearable devices, wherever they are, and this can really improve the adoption of technology, meaning that you can see the results of your algorithm wherever you are. So if I'm in Sainsbury's and then there's a referral comes through, I can see it on my phone, start to make treatment decisions and affect better patient care. Next slide, please. And then finally, we need to think about measuring impact. So we've got to measure impact of any change, any innovation, and in particular of AI, because of the concerns around sort of black box issues and trust that we're encountering as AI is being deployed in the real world. And the NHSX are really taking this up with some of their initiatives recently, funding projects to look at the sort of real world adoption and also impact of AI solutions in the NHS. But the important thing is to, again, remember what's the value you're adding, and you've got to measure outcomes relevant to that value. You've got to measure what's important to the person who's going to benefit, to the beneficiary, which is patients. And because if you can treat patients better, then everyone's happier. So you've got to be able to see the wood for the trees. There's no point in looking at your diagnostic performance, your horsepower, if you like, of your algorithm. You need to look at the ability of it to get the kids to school. Next slide, please. So that's what we're doing. So we have a working group that we've enacted across our stroke network with representation from every hospital across the trusts, both specialist and non-specialist centres, both stroke physicians and radiologists. We've got the paramedic representation, the ambulance service representation, patient representation, of course. You've got to have all your key stakeholders involved, and you've got to have measurable benefits that are important to patients and healthcare providers. And here you can see an example of some of the data we're trying to reproduce. This is some work from Italy showing the impact when they put in AI to their stroke system, showing a jump in the number of patients treated and therefore, improves patient outcomes, not thinking about your horsepower, but thinking about getting the kids to school. And final slide, please. So this is the final slide to just to sum up. I hope I've persuaded you that it's really important to understand the problem when you're deploying AI. It's not a solution for a solution's sake, and you've got to address an unmet need and design the solution around that unmet need and the pathway that you're trying to improve. The best solution isn't always a Ferrari, and clinical significance always trumps statistical significance. The experts you need to help inform your design of your solution need to be the real world providers. They're not the self-appointed experts. They're not the academics in an ivory tower. They're the people who deliver the change, who actually know what the performance characteristic needs to be. And then finally, you need to be able to measure added value to your intended recipient in order to demonstrate that your innovation is worthwhile. Thank you very much.